What is the difference between hypermobile Ehlers-Danlos syndrome EDS and hypermobility spectrum disorder HSD? That question comes up a lot, not just in this forum, but a lot in general. Those are very artificial constructs. So backing up a step, EDS, Ehlers-Danlos syndrome, is one of more than a dozen, 13 or so different types of defined genetic disorders that in some way or another affect connective tissue, affect collagen. At the very base of all of these types, for the most part, people are hypermobile, meaning their joints move more than they should to some degree. Skin can be hyperextensible, extra stretchy to varying degrees. Far, far and away, so something like 90% of all cases of EDS that get encountered are going to be the so-called hypermobile form. So while the hypermobile form is genetic, we feel very strongly about that. It certainly seems to be what we call autosomal dominant, meaning that there's one abnormal gene and you only need to get that from one parent. So some diseases are dominant, meaning that if either parent carries the gene, then if a child gets that gene, then they will have it. So again, if a parent has an autosomal dominant disorder, then each kid they have would have a 50-50 chance of getting the gene that causes the disease. That's in contrast to so-called autosomal recessive disorders, where in order for an individual to have that disorder, they have to have two abnormal genes. So in other words, they get one from each parent. And then in those situations, the parents are what they're called carriers, meaning they're not symptomatic because they only have one abnormal gene. And then when the child has two abnormal genes. So most of the EDS, with the exception of some of the more rare ones, most of the forms of EDS are dominant. And that goes for, we think, hypermobile EDS. There could be huge variability amongst family members, which makes it hard. So it may seem like there's no family history, and the parent that you got the gene from might, not manifest it, or might not have been aware of it, but by the time you're symptomatic, they're older and they may not seem to be hypermobile, or their symptoms are so mild and meager in comparison to those that you and other family members may have that it may seem hard to believe that they have it. So even though hypermobile EDS is felt to be genetic, right now, at the present time, no one knows that there's no gene or genes that have been identified. So in contrast, the much more rare forms of EDS, by and large, there's been a gene identified, at least for many of those cases. And so right now, the only way that we do diagnose hypermobile EDS is based on so-called clinical criteria. So, and these are admittedly arbitrary. A group of geneticists got together in 2017 in terms of the most recent criteria we used, came up with these criteria. And this is where it gets confusing. There's basically three separate questions, if you will. So the first question is the person hypermobile? And even that's already arbitrary, and that's defined, for better or for worse, based on something called the Baton scale. And that's a measure of can a person, how much can they bend back their pinky finger? Can they bend it back more than 90 degrees? Can they pull their thumb against their forearm? Do their knees hyperextend? And basically there's a potential to get 9 points, or anywhere from 0 to 9 points on the Baton scale. Most people will have some points on it. So basically 4 or less for an adult is considered normal, and 5 or more for an adult is going to be abnormal. Once you're abnormal, you don't get extra points for having more hypermobility. It's sort of, do you meet criteria or not? So that's just the question is this person hypermobile? So once upon a time, really anybody who is hypermobile with maybe a couple of other issues would then be considered to have had Ehlers-Danlos syndrome, and at the time they called it EDS type 3. Appropriately, geneticists and other people working in the field said, hey, not everyone who's hypermobile has a disease or disorder. And so they wanted to have a better way. So take this issue of, hey, somebody's hypermobile, then they have to have other features before we would say, yeah, you have a disorder, you have EDS. And then they changed it from calling it EDS type 3 to hEDS, or hypermobile EDS. So, are you hypermobile based on your Baton score? If so, then now there's 12 different points and you need to get at least 5 of those. Again, the 12 points that they chose are ultimately arbitrary, and the number 5 as the cutoff is arbitrary. Is your skin abnormally stretchy? Is your skin abnormally soft? Again, not very scientific, because this is all sort of, again, up to the interpretation of the person doing the assessment. Are there certain types of scarring that happen? Are there stretch marks that happen before any pregnancies are not related to weight changes? Is the palate sort of in your mouth higher arch than normal? Are there certain heart issues like mitral valve prolapse? Are the fingers longer than normal? Are the arms longer than they should be with relation to the height? And again, there's 12 different points. So if you get 5 points, 6 points, 5 or more points, then you have Ehlers-Danlos syndrome by and large. If you have 4 points or less, then you don't. So it's very arbitrary, and that's the long and the short of it. I mentioned that there were 3 components. The third component is there a family history? So if you've got a sibling or a parent, so-called first-degree relative, a child who does meet the full criteria for EDS, then you get credit for that, and then you would be said to have EDS. So it's kind of weird. So like if you come into my office and you have a 7 on your Baton scale, you're hypermobile, you have 4 points of those 12 possible points, then technically you have hypermobility spectrum disorder, generalized hypermobility spectrum disorder. If you came that day to your office not by yourself, but brought your sister, and I looked at your sister and she had a Baton scale that met criteria for hypermobility, she had symptoms, and she had 6 points out of those 12, she would meet criteria for hypermobile EDS, and therefore you would meet criteria. So again, you can see the sort of artificial and sort of logistical nature of how these criteria get made. The other component is, make sure there's not other conditions that can mimic it. In my experience, that's very uncommon, and it really comes down to, again, is somebody hypermobile? So there's problems in both of the 2 major criteria. Again, one, the arbitrary nature of those 12 points, and the Baton score itself. Some of the most hypermobile patients I've come across who have EDS, their Baton score may be just 3. Their spine may be hypermobile, their neck, they may be hypermobile in ways that the Baton scale doesn't capture. Men, by and large, tend to have lower Baton scales than women, so it can be harder for them to get diagnosed. And then if you show up in my office when you're 40 versus 20, even that can be hard. Some people can be hypermobile, up until their 80s throughout their life, but some, we definitely will observe that even age 30, 40 or older, people who may have had a higher Baton score don't. So they're flawed criteria. Those of us who are really involved with EDS and hypermobility do and need to take a more nuanced view. And unfortunately, the current criteria don't take into account what we call comorbidity. So what we realize is, most people with hypermobility disorders, so EDS or HSD, or a high percentage at least, will have things like POTS or other problems with their autonomic nervous system. They'll have digestive issues. They'll have something potentially called mast cell activation syndrome. They may be predisposed to structural problems like cranial cervical instability, CCI or Chiari. We'll be talking about that because there are a lot of questions about those. So hopefully, in not too distant future, one or both of a couple of valuable things will happen. One is we'll have criteria that sort of take a broader view and look at these comorbidities. Obviously, it'd be great if we had genetic tests for hypermobile EDS. Nobody's sure why, despite hEDS being the most common form, why nobody as of yet has been able to identify a gene. There's a researcher in South Carolina who says that he's identified one, and we're hoping that soon his work will be published in the medical literature, and we'll learn more about that. Even so, I assume that's just going to be a subset of all the hypermobile EDS, but hopefully we'll have more tests available.